And we are recording. Okay. So I'll hopefully be mercifully brief. I just want to go over the respiratory system. The interesting part about respiratory is not next week, but the week after is we'll look at the pulmonary function studies. I think from a physiological standpoint, and I think it's important for us. But this is the anatomy part of the program forthcoming. And then as you can see, I have like all these PowerPoints, and I'm going to show you the slides and give you the logistics for next week. Because what will happen when we're done, yeah, I'll have to do it rather. I don't know when the lab gets done in here before we start. I'm guessing around 1, so I'll have an hour in here. I'll have to get busy getting everything set up. But that won't. It's not going to be as difficult as all that. So not necessarily my. Where did your? I'm waiting for yours to come through. They're taking a long time to get these recordings done. And this one was relatively short. I did this after yours. Okay, what are you going to do? All right, so let's start. This is respiratory. You're going to find this blackboard wise. Here, I'll show you. Week 4. And again, at no additional charge, we have a respiratory outline for your viewing. Don't have to thank me. Money is always acceptable. Okay, it's locked. So read only. There you go. All this. So I took all of these things are things that'll be appearing not for a long time before we do tests or anything like that. But there's a fair amount in this kind of a thing. I'm getting a lot of mileage out of this. I did this about 20 years ago. I hurt myself doing that, patting yourself on the back. Okie dokie, respiratory system. So I have a very simple introduction. Yes, supply the blood with oxygen for cellular respiration, get rid of CO2, a waste product of cellular respiration. Yeah, it's intimately associated with the circular system. Yes, it's intimately associated with smell and speech. And in short, you can summarize respiratory system very briefly with one phrase: in with the good air, out with the bad. That's about it. It's all about, there's a lot of physiology to it. There's a lot of basically how we bring in the air, how we expel the air, and and we don't have to do a whole lot to accomplish that. I don't necessarily love that they've had this for 20 years. Uh, to me, I don't use the term external and internal respiration. I mean, to me, it's what happens in the lung would be pulmonary respiration. What happens so that's bringing in the oxygen, getting rid of the carbon dioxide. And at the cellular level, what they call internal respiration, to me, is merely releasing the oxygen from the bloodstream to the cells and picking up their waste products, particularly carbon dioxide. That's about it. So the ventilation is the breathing part, bringing it in mechanically, and the transport is by the bloodstream. By and large, we've already covered that. So the systems, I mean, it's very accurate from the diagram that you see here. The accuracy is such that, look, it involves this portion. We have to bring in the air, get it in the lungs, somehow deliver it to the bloodstream, pick up the waste products, utilize the heart and the circulatory system to basically maneuver it all the way around, either going to the lungs or coming back from the lungs, etc., and then distributing it to the tissues, and then of course bringing it back so that we can, sort of like wash, rinse, and repeat. That whole type of thing that goes on. It's very concise. Okay. The interesting part about it is, again, this beautiful use of limited space. So think of how big your lungs are, how much room it occupies compared to the rest of your body. You have a nose, you have a throat, you have the trachea in your neck, and you have your lungs, which basically are from your shoulders down roughly to your diaphragm. That's it. Yet we have an immense amount of surface area. So once again, it's this sort of magnificent way that we create an immense amount of surface area anatomically in a rather limited space. Would be the way I would describe it. So we divide it. Now, again, you're starting to see a pattern of of anatomical and functional kind of ways that we view things in anatomy and physiology. So we have an anatomical system and a functional system that are not necessarily the same. So anatomically, the most common diagnosis that anybody gets when they go to any doctor is URI, upper respiratory infection. Constant. Colds, minor case of the flu, sore throat, sinus infection, earache. Those are all upper respiratory infections. How do we define that? Roughly, depending on the author, the defining point is typically around the larynx. Okay? And so to me, when someone gets a cold and it ends up in a sore throat and they get laryngitis, that's an upper respiratory infection. If they start with laryngitis and the next thing you know they have difficulty breathing or pneumonia, that's a lower respiratory infection. So COVID basically would be identified as a lower respiratory infection as opposed to the common cold. So the anatomical divide, whether you think it's part of the upper or part of the lower, is the larynx. So we'll leave it at that. So this author basically includes the laryngeal area, which I just talk about ever so briefly, anatomically, and the trachea, the bronchi, their branches, the lungs, and finally where the exchange actually takes place and where this immense amount of surface area is, the alveoli or alveoli, depending on how you pronounce it. The upper respiratory is the nose itself and the nasal cavity, the sinuses that surround it, the pharynx, which is your throat, and then basically the transition point to larynx and trachea occurs at sort of a commonality because our throat serves for air passageway and food and liquid passageway, and we divide it by way of the epiglottis because that passageway basically divides into the larynx and subsequently the trachea anteriorly, and the esophagus and subsequently the digestive area posteriorly. And that's our next big unit. We have yet to do digestive, urinary, and then male and female reproductive. So we're roughly, this is halfway week. If I'm really on top of my game, I can get the second exam and midterm grades because we're doing it Tuesday. I'll let you know. I'll email you if I was able to get those in and processed by the time. Because the midterm grades are like due, I think, this coming Wednesday at whatever. And they always insist on us submitting them. A word about midterm grades from everybody. I've worked in a lot of schools, and some of them, the midterm grades are only when people were doing badly. You know, because the midterm grade doesn't mean anything other than alert you to the fact that maybe you're in trouble. I think, but I don't think anybody here is in desperate trouble. Well, I can always be optimistic that maybe you will be after the exam. I'm hoping. Don't look at me like that. Sorry. Moving on. First diagram. None of this stuff is on the practical next week. The final practical starts here. Okay, there's nothing from the immune system on it or anything, or the lymphatics, because there's not much to talk about anatomically. That last one is respiratory, digestive, urinary, reproductive. That's the final material that's there. So you have a nasal cavity, surprisingly bigger than you think. Okay, more surface area than you would think. You have the shared passageway we call the pharynx. You have the laryngeal area. Here's the divide with the epiglottis. And here's the esophagus posterior or behind it. The rings become very apparent as we get to the trachea and very distinctive. They divide, and the divide is significant, going between the right and the left lung. So this is an area where we have two manifestations of an anatomical basis of disease. You will see the eustachian tube, and I talked about it a little bit with regard to the ear. Babies, when they're born, that eustachian or auditory tube that you learned about in the ear is basically horizontal. So when a baby sleeps, on their back like that, anything from the nose area drains back to the ear. That's why the anatomical basis why we see ear infections much more common up to maybe between ages 2 and 4. Because by that time, the baby enlarges, it changed skeletally, now the tube is pointing more downward, and it's going to drain without backing up into the eardrum. You see the same thing here, except it doesn't change in the lung. What you're going to see is that the right, this side, that I'm pointing to here with a cursor, that the right, we call primary or main bronchus, which is the divide, the fork between the trachea as it ends, is pointed much more downward. Most of the time, pneumonia comes from particles assisted by gravity that go down. Most pneumonias are right-sided. The reason it's not on the left is this is much more at a horizontal. This is more vertical. This is more horizontal because it's got to go over the heart. And it's a lot harder to make a sharp left turn and go basically parallel as opposed to just having gravity go straight down. So those are two major anatomical bases for disease. And I always want to alert everybody to that. So you can glean a lot out of just looking at these. But again, if you're looking at it in the overall context of how much of you it occupies, at least if you measured it surface-wise, what you would see here, not a lot. When you get inside, you're going to see that the bronchi, starting here at the end of the trachea, divide approximately 23 different times. They get progressively smaller and smaller. And so because of that, these air passageways that are located in the front and the back and the middle, along the sides, are many. And they have a tremendous amount of surface area available for exchange. And it's the recurring theme that I teach all of my anatomy and physiology classes, whether they're people going to medical school or people who are just taking it for information, and all in between. We have so much lung available that it's not a problem to us until it gets to the point where it's such a big problem that it's irreversible. We have so many backup systems, so many ways that air is directed to area where it can be satisfactorily oxygenated, where it can give up carbon dioxide, where it can obtain maximum oxygen, that it's not until all of a sudden someone with chronic respiratory disease finds out, and I'm sure I've said it to you before, all of a sudden they get a terrible cold, they can hardly breathe, they go to the doctor does some tests and goes, you're going to be on oxygen for the rest of your life. Well, I was fine yesterday. Now I have to be on oxygen, and the answer is yes. Because all of a sudden everything fails at once. It's the great thing about the human body, it's the curse of the human body. Everything's fine until it's not. And you see it again and again and again. And respiratory as much as anything. So I take this to heart because I'm fortunate I'm not the one talking to you with the oxygen pump from all the thousands of cigarettes that I smoked for 40 years. It's my mom again. We both love smoking. It's terrible. Even if my dad made her quit. They both smoked 3 packs of cigarettes a day. For years, forever. When my dad met my mom in the late 30s, she was smoking Camel Straights. Those are non-filtered Camel cigarettes. Really harsh. And these were World War II vintage cigarettes. Lucky Strikes and Camels. And my friends used to joke that if we go to your house, Lou, what we have to do is reach anywhere you're sitting, and we'd either an ashtray or a deck of cards. That was my household. The end of stuff. My sister never smoked a day in her life. And my dad quit after all those years before the Surgeon General's report came out. And then he nagged my mom for the next 4 years. So she finally quit. Every so often I'd catch her sneaking one. Go to the beauty parlor, standing appointment. She was that generation. Fridays at 10 o'clock, I'm getting my hair done. There's a picture somewhere. I have to have my sister send pictures. She's in charge of that. So, you can read through this as well as I can read it to you. Let's look at it. We'll start with the nose, the entry point. So mostly it comes, we can breathe through our mouth, certainly, but the design is sort of in through the nose and out through the mouth. Okay, and what does it do? It moisturizes it, it cleanses it, it warms it, because it makes the exchange of oxygen and carbon dioxide easier if there's there's a small amount of moisture and the temperatures are about the same internally and externally. The cleansing principally comes nose hairs that prevent stuff from entering. They're part of your immunological system. So that's really the role that they play within that. And then everything else kind of comes in. Yeah, resonating chamber, you can tell if somebody has a cold or, so, you sound more nasally or it's hard to hear. Yes, smell is in there as well. Anatomically, you have the nose and the cavity itself. So if you magically could take this all away, you would see that entry level would be the cavity. And then there's all this anatomy, and I don't care about it. Between the eyebrows, the bridge of the nose, pretty famous term that's there. All these nares are the nasals, and who cares? Everything of the nose, other than the bridge of the nose, those are the nasal bones. That's the bone. Everything else is cartilage. And all the cartilage in the respiratory system, except for the epiglottis, is hyaline cartilage. That's the same cartilage that covers your bones and makes joints. That's the cartilage between your ribs and your sternum. This is all hyaline cartilage. That's the predominant cartilage that's there. And so there's not a whole lot else to say about that. So all these illustrations, a nice looking nose. Just saying. Right, I had a rhinoplasty, 1986. I had the classic, what we refer to as the Jewish nose, down here. Anybody ever see Spaceballs, the movie? She had my nose. I'll have to show you the clip. Here are all the cartilages, and they all have names, and I don't care about them. There's a divider called the septum. It's cartilaginous in front because it's flexible, and it's bony behind that. You remember the perpendicular plate of the ethmoid bone, maybe, and the vomer, which is a facial bone. They are really the bony portion of the nasal septum. So when you have somebody breaks their nose, typically you can sort of like reset it and sort of splint it there and hold it in that regard. So there's not a whole lot, to me, there's not a whole lot to say. The opening, nose hairs that are basically a filter, a couple of different kinds of lining. You have the sensory portion for smell and the respiratory portion that's starting to work on the air that comes in. It has mucus that serves to moisturize it. So, and that's really the extent that's there. So there's not a whole lot. You can go through all this stuff. We have, as you remember from smell, you have to have a little bit of that mucus basically is able to dissolve what they call the odorants and allow for smell to really occur. And obviously there's defensive materials in there. The hallmark epithelium, please remember, ciliated columnar pseudostratified epithelium. So it looks like multiple layers. It's really only one. They're replaced very, very frequently. And the whole idea is the mucus plays a role in trapping the particles. And the cilia sweep it in some way, shape, or form, either from your nose to your throat, from your throat towards your mouth, from your larynx up towards your mouth so you can expel it in some way, shape, or form. The nose has a number of bony structures that increase the surface area we call conchae. So there's 3 different levels of them. That's about all that they have. And again, this is what they do. 4 bones have sinuses. I use the acronym FEMS: frontal, ethmoid, maxillary, and sphenoid. There's also an air sinus behind your ear. They're all like resonating chambers. The good news is that's the purpose they serve. The bad news, they're like little cul-de-sacs that come off the nasal cavity, so stuff can get trapped in there. So when you have a sinus infection, And understand infections of the upper respiratory, about a third of them are viral and about 2/3 are bacterial. Bacterial ones can do some damage. So you have some real problems with those. So the nasal cavity is bigger than you think. And so all of these are little openings into the sinus areas. As you can see here, the big opening is back here. Okay, that's the opening. Oh, God, hold on. That's a small problem. Hold on. Yeah. Oh, here, hold on. Small emergency. Oh, God, this is driving me crazy. Stop. Don't have children. Okay. See if this will quiet them down for a bit. Moving on. So, this is the big opening. That is the opening for the eustachian tube or pharyngotympanic tube that works its way up. That's there. You don't get a lot out of that. Inflammation of the nasal area, they call rhinitis. Sometimes you'll see that as a diagnosis if you go to the doctor. Okay. Hold on. Okay. And moving on. So, and the lining is there. So infections easily can spread because of the continuous nature of the lining. Here's the sinusitis. Not a whole lot you can say about that. So that's really it for the nose. There's not a whole lot in there. The pharynx is sort of like a funnel that's open in the front. And so it's open into the nose, called the nasopharynx, into the mouth, called the oropharynx, and in behind the voice box, called the laryngopharynx. And it's a shared structure with digestive that you will see. Uh, so here are the three structures that are there. Okay. Let me see what else we can do with that. So you can see where they're located. The nasopharynx being the most important because of the eustachian tube. The other are relatively small. Okay, and then we'll get here. This is the critical piece. This is the epiglottis. Okay, moving on. So again, the nasopharynx, and it's got pseudostratified columnar epithelia. It changes a bit in the mouth because when food's coming in, it's more abrasive. And so that lining changes to stratified squamous, non-keratinizing. This goes along with what we learned about the lymphatics. Okay. And so all of these things are there. Pharyngotympanic tubes that are part of it, the tonsils and the adenoids. And the oropharynx, like I said, stratified squamous. None of these are that important. I'm not going to ask you anatomically to identify palatine or lingual tonsils. You'll see the illustrations that are there, or they'll be in that previous unit. And then finally, you get the laryngopharynx. Again, it's still shared, and things don't start to change until we get through the larynx. Please stop this. Stop. So moving on. So there's not a whole lot that you can say. It's still stratified squamous that's there. So you don't gather a lot out of this particular thing. Yes, if there's tonsils or adenoids are swollen, there's problems, and that's when typically we see problems that are associated and they have to be addressed, whether it's a tonsillectomy or removal of the adenoids or any type of treatment for that that's there. The lower, and we might as well go along with this author and say it starts at the larynx. To me, the bulk of the anatomy for you folks to know is going to be trachea, bronchi, and then the alveolar area. Functionally, there are two zones that it's broken into. Everything I've told you about so far, nose and throat, those different levels, the trachea, as you will see, even the start of the bronchi, are all part of what's called the conducting zone. They're about moving the air in and out. So that's transportation. Oxygen in, carbon dioxide out. When we finally get to what's called the respiratory zone, we're at the point where we're so close to where the exchange of oxygen and carbon dioxide take place that we don't have to move oxygen and carbon dioxide. Simple diffusion will take over. You're right next to the membranes. That's called the respiratory zone. Why this is important will dovetail into 2 weeks when we start to look at the different kinds of problems that people have. People have chronic breathing problems. We classify them as either obstructions, that means blockages in the conducting zone, or true respiratory problems where they can't exchange. So you're going to see that's why this distinction, it's really very subtle anatomically, and I'll show it to you. So here's what happened. The respiratory zone is finally in what's called respiratory bronchioles. They're microscopic, they're tiny, and they open in to these layers of cells that are called alveoli, where the exchange takes place. As long as they are not present, everything else is in the conducting zone. So it's air movement, warming it, moisturizing, etc. There's not a lot to say. The larynx is probably around here. Your best anatomical landmark is your Adam's apple, which is a cartilage that guards the anterior portion of it. Okay, and because it's made of, and that's what cartilage does, we call it patency. The cartilage makes sure that we have open air passageways. Okay, those open air passageways, basically, a cartilage, because it's somewhat rigid. So whether it's the rings of the trachea, whether it's the rings of the bronchi, whether it's the cartilage like your Adam's apple that guards the larynx, they all are designed for one thing. They make sure that it can't be compressed or squeezed. That's the beauty of cartilage. Same thing in your nose, the cartilage in your nose, any of those structures allow it to maintain. So the word we use is patent. So patent would be something that you'd file if you had an invention. Patent is the way we pronounce that. So the larynx not only directs the air in one direction and the food in the other direction. We have vocal folds. Okay. There are 9 cartilages. There's only 3 that you have to be concerned with. The thyroid cartilage, that's the big shield anteriorly. There's models here. Actually, have a decent. Apologize for the interruption, Mike. So this isn't a bad model. This is kind of thought, the hyoid bone, which has attachment to swallowing and speaking, is kind of above it. You can actually somewhat up here. So the big area here in front, this is the thyroid cartilage. It's huge. Much wider and larger in the front. Not so big, they don't really show it here in the back. Okay? And at puberty, it begins to enlarge, and men much more so than women. And you get this called the Adam's apple. So this is sort of this process that's in front of it. Posteriorly, you have a cartilage in the back called the cricoid cartilage, which is larger posteriorly, less so anterior. Okay, and then lastly, you have one, and the way they've done it with this model is they've made the epiglottis is made out of elastic cartilage, but when we swallow, it blocks the passageway for air so that the food will travel behind it. So, and effectively the pharynx divides then into the larynx anteriorly in the esophagus. And there's other little minor cartilages you can see, the retinoid cartilage, etc. So classical anatomy, there's 9, and there's ligaments and muscular structures that facilitate that. And a lot of them, if you look in this, will play a role, and I don't know if this model does it, but effectively it plays a role in speaking, creating an opening. That's there. So when I'm speaking, when you're speaking, you're moving air and creating sound with a combination of movements here in what's called the glottis, that's the opening in the larynx. So, and there's so many nuances. So I don't really get into it because I don't understand it so well as to the mechanics of it. So you can see the thyroid cartilage, much larger in the front. Like I said, open book, that you would have anteriorly, with a prominence called the Adam's apple, as we all know. The cricoid, ring shaped, larger in the back. These other paired ones you don't have to know. And the epiglottis. Again, the epiglottis is the only one that's not hyaline cartilage. It covers that inlet during swallowing. There's taste buds on it. So you can see anatomically, the hyoid bone would be up here. Here's that laryngeal prominence in this anatomical model. Here's the cricoid below it. Then you can have like the sternal head and the clavicular head even farther below it here. That little notched area, that jugular or manubrial notch is, again, an anatomical landmark here that we'll utilize if you have to do a tracheotomy. Because if this is blocked, jammed, ruptured, fractured, then sometimes you have to put a breathing tube in this way. That's what a tracheotomy is. See, I use this illustration all the time. So you can see it here. The thyroid cartilage, the cricoid cartilage, and then after beneath that, we start the tracheal rings, which are distinctive as well. I do not do the vocal cords or the vocal ligaments or that type of stuff. I don't understand enough to tell you about it, so I'm not going to tell you about it. And sometimes I use this illustration because it utilizes the epiglottis fairly distinctively. And then this is the view that you would see when someone is passing an endotracheal tube, like for anesthesia. Okay, and I'll put a breathing tube in somebody. Particularly if you flip somebody in position, you start on your back. If they have to go on their tummy or on their side, to maintain the airway, you have to put a tube in. This is sort of the view that you see, because you want that tube to go through here. And this talks about voice and things like that, and laryngitis. The trachea, the rings are C-shaped. It's not as long as you would think. It's only about 4 inches long. Maybe there's 15 to 20 rings. They are C-shaped and open posteriorly. So they look like, and they really maintain the opening of the trachea. There's a muscle called the trachealis, and behind that is the esophagus. That way, when you eat something, there's a little bit of give. So if you swallow something, it doesn't. If it was circular, theoretically, it could block food going down, if you want to think of it that way. At that point, we transition back to ciliated pseudostratified with goblet cells. The subcute mucosa is mostly the cartilage and some other related structure, and it's called adventitia because it's not a moist lining; it's sort of a dry. There's the trachealis, and that when we cough, that helps to expel mucus. And the very last one of those rings of the trachea is unique. It's called the carina. It's very sensitive when particles get there, so it triggers a lot of coughing. And it's very unique in its structure because it's somewhat triangular, and you can see the divide for the primary, the right and left primary or main bronchi. So So here they are. All the things that are there. You can see the C shape. This is anterior. This is posterior. So imagine that diagram that way, if you can, with the esophagus behind it. So most of that mid layer, where like in a blood vessel would be muscle, okay, in this case it's cartilage. And here you can see within it the cartilage that's there, the pseudostratified, some connective tissue beneath. And that's what cilia look like microscopically when they're healthy. They used to have one with somebody who was a smoker, and you could see just little traces of cilia. The good news about somebody like me who gave up smoking, well, these nearly 15 and a half years ago, these all grow back. So the good news is they grow back. The bad news is that someone who smoked for that long, my risk of lung cancer is always elevated. That doesn't. So, it's just the price you pay, along with that bladder cancer I have. So all of these things, and this is the big problem when someone like me, I'd have a cold that would last for months. I'd be bringing up stuff disgusting. Heimlich maneuvers, using pressure from the diaphragm, sort of like generating a force from underneath here, sort of pushing up from the diaphragm. It has to be done correctly. You can even do it to yourself if nobody's there to help you with it. And then we begin to see the branching. And the branching is fairly unique. So it starts with the conducting zone giving rise to the respiratory zone, et cetera, and you'll see that. We're going to start with the branching. So these 23 orders of branching are basically the conducting zone. You have the right and left main bronchi, okay? Again, the right is wider, it's shorter, and it angles much more straight downward, where the left goes over the heart. And that's where the lungs differ. The right lung is technically larger, even though they have the same, more or less the same number of portions interior. The right has 3 lobes, superior, middle, and inferior. The left, again, just has superior and inferior. So there's 3 on the right, 2 on the left. And you'll see the distribution, though they both roughly have the same number of segments. Most authors agree there's 10 on the right, maybe 9 to 10 on the left. So I don't think there's a substantial amount of difference. And then they're going to start to branch until sometime when we can't see them. And that's what we call terminal bronchial. A bronchial is less than, you and I can visibly see structures that are about a 0.5 millimeter. Once it gets to a 0.5 millimeter or less, then you really can't see them. And it's a pretty good illustration. Here's the carina, this one that's very, very sensitive. It's triangular. Rather than being more of that sort of a C shape, it's much more triangular with the openings. So the right primary has 3 secondary bronchi. One that's going into the superior lobe, one is into the middle lobe, and one is in the inferior lobe. Where on the left, there's only 2. You have a secondary bronchus going into the superior lobe, and then one carrying it down to the inferior lobe. So there is a distinctive difference. Why that was important years ago, they used to remove lobes of the lung when they were diseased. Nowadays, we remove actual segments because the technology is better. So what happens? The conducting zone is really all of these structures, all the way down. So the conducting zone, the bronchi, the rings of cartilage are circular. As they get smaller and smaller, those circles of cartilage give way to plates, and then they're replaced by smooth muscle. And when we finally get down into the respiratory zone, now the cartilage effectively disappears and it's just smooth muscle. So the rings become irregular plates with elastic fibers. The lining gives way from pseudostratified to cuboidal, and finally to simple squamous. And again, this is where most of the way we see it. When we get into the respiratory zone, you'll see the opening into these sacs called alveoli. As you can see, there's about 300 million. So most of the lung are these air sacs where the exchange takes place. And it's a really good illustration. The terminal bronchioles, here's a bronchiole, here's a terminal bronchiole. These are smooth muscle. When they become respiratory, we begin to see these little outpouchings of alveoli. And the alveoli are really made up of circles of cells. The best analogy for that is if you like to do puzzles and you ever got something called a puzzle ball. Okay. So a lot of times jigsaw puzzles come in ball shapes. And that's what they look like, and mostly elastic fibers. And what they do is they have a lot of surface area. That's the beauty of all these alveolar cells. So this little grape-like cluster has multiple cells that are in it. And so you can see it here. These are areas that are filled with air. Where they're thicker here and darker, this is sort of the terminal bronchial area. So this is what a normal lung looks like. It's though you took, if you go backwards and took this, sliced it sort of the long way, and had this, and you put like ink on it and put it on a piece of paper, this is what you would see. So you're looking, and the important thing about the air is when lungs are damaged, what emphysema means, trapped air. It doesn't mean lung damage, it means trapped air. And what happens is all these little nooks and crannies that are basically cells with alveoli have deteriorated or are absent. So you get wide areas with a lot of air and a lot of darkened area here that would suggest that the exchange is much more difficult. So even though it appears to be more air, it's useless air because it's trapped. That's something we're going to look at in 2 weeks when we talk about pulmonary function studies. It's a very, the distinction, and let me go farther. Everywhere that you have a level starting at the main bronchus all the way down to the terminal and respiratory bronchioles, they are followed by, if you remember the heart, you have a pulmonary artery and pulmonary vein. So what happens as they branch, you get pulmonary arteries, finally pulmonary arterioles, and pulmonary venules bringing back the air. So it's constant, they're forever surrounded by blood vessels and capillaries. That's the interesting part about that, and that's when we're talking about tuberculosis or lung diseases like pneumonia. The big problem is when there's damage, now the bacteria can get directly back into the bloodstream. And tuberculosis and those infections can seed all over the body. This is what a casting would look like in the capillary area. And so what we see is, and here's that sort of puzzle ball analogy, what you have a lot of are basically what are called type 1 cells. That's where the exchange, because they share a common membrane. So on the exterior, you have capillaries. On the interior, you have the alveoli. They share a basement membrane. So oxygen and carbon dioxide can basically go in opposite directions. The oxygen from the lungs will oxygenate the red blood cells. The carbon dioxide will be given off and go into the alveoli. In addition, you have type 2 cells. They make something called surfactant. That's sort of a moisturizer that allows the lungs to open and close. The lungs without the surfactant would adhere to one another. That's the difficulty and the problem associated when someone has a collapsed lung. It sticks to itself. That's why you have to reinflate it. So it's really damaging. So you have those type 2 cells. They become active roughly 24 to 26 weeks of gestation. For years, when a baby was born prematurely, like this, my son who's texting me with all these problems, he was about 5 weeks premature. So maybe that's 35 weeks. They're making surfactant, they're able to breathe. But nowadays, we can make the surfactant, and that's why babies even born who are extraordinarily tiny, even under 26 weeks, can survive. And there's also a tremendous amount of white blood cells. They're like, again, they're like little sweepers, like little Roombas, who are just gobbling up debris, and there's millions of them. And so you'll see the lung itself is rather large. It has a surface against the ribs and against the costal cartilages. The tip, the apex, is under the clavicle. The base is against the diaphragm. The hilum area is where the entry and exit point for pulmonary arteries and pulmonary veins, bronchi, lymphatics, nerve. And again, it's divided into lobes. And on the left, we have a rather substantial notch for the heart. That's that area. And it's a pretty good illustration to see. Here's the heart, but so these pleural cavities are unique spaces. They're closed. So if one lung would collapse, it doesn't mean the other one. We really get problems when both lungs collapse. We call them, now we just used to call them lobules, now they call them segment. 10 on the right, somewhere between 8 and 10 on the left, though 9 and 10 seems to be the number. And now in disease, we're able to just remove the segment itself, which has really improved recovery. A lot of elasticity. So when we'll actually look and dissect the lung in about 2 weeks when we're doing this activity after the practical, and this is actually what it looks like. These are like 23 orders of branching. So this is almost like a pouring where it's been stained. You can see how they get progressively smaller and smaller and smaller. The right going straight down the left, more horizontal over the heart that are there. And we'll get into some of these nuances with regard to the branches that are there as well. The lining of the lungs is called pleura. You have one against the wall, and you have one on the outside of the lung itself. That's the parietal and visceral pleura. There's a thin layer of fluid, and that's important because when we inhale, mechanically, our chest expands. The diaphragm flattens, the intercostal muscles expand our chest, and that little bit of fluid adheres. So it really provides an increase in volume of the lung. And all of this is about, as the lung volume increases, the pressure decreases, and it allows, and it helps to draw air in. It's all about pressure and volume maintaining a constant relationship. Famously, that's referred to as, I love this, the ideal gas law. Back to being chemistry. Inflammation is pleurisy. Fluid can limit the ability. When it gets in there, it has to be removed. So when we get a pleural effusion, fluid in the cavity, it makes it difficult to breathe. And voila, that's basically everything that we have to share with you for this part. Everything else is more functional. In the next section, which we'll do after the practical, we'll talk more about really sort of the nuances of how those segments work, how the physiology works. There's more of a physiological lab. We use the technology. We can sort of as a group do a group dissection. Everybody can take a look at it and take a look at the lungs. So that's all of that that's going. So the next and the last part of this is more of a review of the slides. So here's what's going on for next week's practical. Break. All right, and we'll look at all of these that are there, and we'll get into all the different things that are part of the different kinds of respiration. So let me get out of this one. The outline that you have available to you. And the rest of this will just be to review the slides, starting And I think we'll start with 13A. It should be here. So 13A, the important part of this is about the eye. Okay? So I'm scrolling down, as you can see, until we begin. And none of these are really on it. This is the first part. So the illustrations that you might be labeling could be this, with the sclera, the iris, the pupil. So that's a possibility. You may see that, or you may see this illustration where you can see the cornea being clear, but being a continuation of the sclera. And the one you will certainly see a lot of is this. You might see this one with the lacrimal apparatus. But the big one, and I don't generally use these for the extraocular muscles. The one that is coming is this one. So you can use this more than once when it comes to the eye, because you have the three layers, the sclera and the cornea. You have the lens, you have the pigmented layer, the ciliary ganglion, the suspensory ligaments in the lens, the iris, the pupil, etc. The blind spot back here. All of those, the macula, fovea centralis, there's a lot on that one. All those different layers from an illustration. So you see that same illustration coming up again. Don't use this one. So I'm trying to get to the ones. It would be this one. So the distinction between rods and cones, bipolar cells, ganglionic cells, that's important. These illustrations will have 3 answers each that we're using. Why I'm doing this, I don't know. Because he has me aggravated. Oh, don't have children. He's having a big fight with his significant other. But I digress. Anybody looking for a 39-year-old boyfriend? It's all right. It's a pain in the neck anyway. He's very handsome. Ever show you a picture? Oh, it's annoying. I'm not trying to pass them off. But I will permit all of you to have a sheet of a reference sheet of regular size paper, 8.5 by 11. And you can put any of the illustrations or any information you want on it. So you may have this, we call it a reference sheet, not a cheat sheet. That would be inappropriate. Yes?
Can it be double-sided?
Yes. Front, yes. Pardon me? Yeah, no, a piece of paper. Like standard, like paper. Can you handle it? Like a printer paper. Don't use that one. Don't generally use that one. So I think that basically covers the eye. I don't really use those. But I did want to show them to you for the sake of this discussion. In B is more optical, so it's not a lot of anatomy per se. I'll look at this way. Let me see what there's any. I don't use any of that. None of that. So I mean, I really don't utilize those. To me, that's more physiological than not. So there's not a lot there when we go through all this. So I'm getting there. I'm not going to use that. But again, you might see, so you know that this is olfactory nerve, olfactory epithelia. So you would be able to see this is now we're dovetailing into that area. And to say so for smell, without getting a whole lot about it, For taste would be the same thing as that they were taste buds, and they have those little taste pores or gustatory cells. So I might incorporate a couple of those slides together or something that looks like that. But that's about as much as you have to announce. You have to be familiar with it. Okay. So there's not a lot left in that one. C has hearing, so you should be familiar with that. C and D have more of the anatomy. Okay. Oh, that's blood flow. I'm sorry. Wrong one. Here we are. 13. Oop, oop, oop. Let me get to C first. Here it is. I'm sorry. So this is the ear. So slides that we definitely use, like this one for the ear bones, you do that one. Okay, so focus on that. Semicircular canals, the cochlea, the vestibulocochlear nerve. That would be part of it. So that's important. Same thing here. So for the one with the bones, you'd use that. And then this would be like oval windows, semicircular canals, cochlea, vestibulocochlear nerve. And this one. So you'd understand when we took I'll get you a closer look, like this: tectorial membrane, basilar membrane, inner and outer hair cells. Okay. I think that's everything from that illustration. Yeah, not a whole lot. I mean, that to me is more physiology than anything else. Now D has a little bit more of it that's there because this is all the peripheral nervous system stuff. So yeah, I mean, I think it wouldn't be a bad idea to know epineurium and fascicles and axons, like you can see here. But certainly a lot of it's coming. Not so much that with this one. Certainly to be able to label optic and olfactory and oculomotor or trigeminal or abducens, that would be important. Maybe the branches of the trigeminal, that would be important. I mean, it's a little hard. It's more of a didactic. The test questions would be more like that's something you would see in the lecture part than in the lab part, I think. And I wouldn't use that. Kind of already used that. So I wouldn't worry too much about these. Okay. And then from a cranial nerve perspective, you might want to be a little bit familiar with this. So you know horns from columns. And I don't, the phrenic nerve's a little, there's not much going, but this, when you start to see this one, it's coming up. So I'd be able to point toward axillary nerve and musculocutaneous nerve and radial and median nerve and ulnar and radial nerve. Not a lot you can do with that. This one's useful because you can get the obturator nerve and the femoral nerve would certainly be part of that. That would be fairly easy to use. And the same one with the sciatic nerve would be fairly easy to use like this. Okay? To be able to use the sciatic, the tibial nerve, and the common fibular nerve and the sciatic nerve. Fairly easily. Okay. Nothing else with that. And that'll do the nerves. And where am I still? This is that's blood vessels coming. Are you ready for blood vessels? And that should be the rest of it, I think. Yeah, oh, heart. Yeah, didn't remind me. Sorry. Okay. The heart ones, okay, something like that, because you can get the chambers, the auricles, the yes, vena cava, the aorta, etc. Not that one. Or that. Oh, that a lot. At least two of these. Be ready. So you have the chambers, the valves, the chorda tendinae, the papillary muscles, the pectinate muscles, the main, the big vessels are all part of it. You got all that. Same thing here. You can have again the auricles, the coronary arteries. So you could have the anterior interventricular and the right coronary artery. That would be there, and this one too. Because you'd have the coronary sinus, the pulmonary veins, the inferior vena cava, etc. Same what we saw before. Not so much there. The only other one that's here, I think, of note would be, it's coming. Going with this. Okay. I think we're good other than that. And then on B, the only thing that's really relevant on B is this guy. Okay. So you'll have that. There's a couple of others. The SA node, the AV node, the bundle branches, endocardial network, and then the EKG stuff. P wave, QRS, T wave, and then a couple of the rhythms, the normal, remember P wave, QRS, T wave, junctional, no P waves, just QRS. You can see the length, but it's not as rapid a beat, irregularities in the T wave, the heart block, and VFib. Yeah. All right. Yeah, I don't think there's anything else there. We're almost there. And then this is the blood flow guide. Coming up. Here. So from a blood vessels perspective, the ones that I use, okay, sometimes this one for major, again, it doesn't have all these labels. I'll just point to big blood vessels that are there. This one, because you can get the vertebrals, the subclavian, common carotid, the internal and the external carotid. Certainly this one with the vertebrals, the basilar, the circle. And again, so, I mean, this one would be fair. And certainly these, and these ones everybody seems to have trouble with. The abdominal aorta, okay. And so this would be the celiac trunk, superior and inferior mesenteric, the renals, the suprarenals, etc. And then the lower extremity, you have, you can start almost anywhere with that, the iliacs, the femoral, popliteal, tibial artery, fibular arteries. And just about the only one I use for the veins. So you have basilic and cephalic and median cubital. Again, coming back in here, iliac veins, vena cava. Probably not so much that. So I'd probably use that one. And I think it's important to know this one to get the idea of that one coming back into the liver, the hepatic portal vein. That's important to write. I think that's it. Okay? And that, every